Welcome back. Antibiotics are important drugs. There's no arguing that they play a big role in treating infections, but they have to be prescribed and used correctly to continue to have a benefit on our health. Tom Richardson is still with me, and joining us now is Heidi Simons. Both Tom and Heidi are pharmacists who are going to talk to us about how healthcare providers are working to fight antibiotic resistance. So thanks for joining us, Heidi, and welcome back, Tom. So Heidi, let's start with you. The biggest weapons, if you will, that we have against antibiotic resistance is antibiotic stewardship or antimicrobial stewardship programs. Can you tell us a little bit about these programs?
Sure. So antimicrobial stewardship is a very broad term that encompasses both inpatient and outpatient programs to help improve selection, dosage, and duration of antibiotics. This is so that we can get the best treatment outcome possible while producing little to no toxicity to the patient and having little to no impact on bacterial resistance. So it's kind of a big term, and it encompasses a lot of things. So we do this by having dedicated reviews of each patient on antibiotics every day and making sure that that's appropriate for what infection they have, making sure how long they're treated is appropriate and they're not unnecessarily taking antibiotics when their infection's been treated, and using the most narrow spectrum agent possible. So not using a cannon to treat a mosquito bite, sort of a thing. We help provide feedbacks to our physician providers on how they're prescribing to help them improve their prescribing habits. We provide a lot of education, educate our nurses, educate our physicians, and our patients to help incorporate the principles of antibiotic stewardship into daily practice and make it reflex as opposed to something to work at. We also work closely with our colleagues in the microbiology lab to track our bacterial samples to see where our resistance patterns are going. If we don't track how resistant our bacteria are, we don't know which antibiotics we might be losing in terms of being resistant, for lack of a better term. Another important point to make is that stewardship involves everyone. So it's not just an antimicrobial stewardship pharmacist or physician, it's all of us. It's all the staff at the hospital, people in the clinics, and our patients. It's a group effort. And the core team, of course, involves an ID physician and an ID trained pharmacist and microbiology expert and an infection prevention expert, but really it's everybody. And using these programs to combat bacterial resistance has become a national priority and a patient safety issue. So antimicrobial stewardship programs have been shown to reduce unnecessary antibiotic use by 20 to 50% and reduce patient length of stay in the hospitals by 1 to 3 days on average. We can also decrease community-wide resistance rates and keep our facilities compliant with regulatory bodies. So there are a lot of benefits. And in 2014, the CDC recommended that all acute care hospitals have one of these programs, and hospitals are doing that nationwide. But now stewardship programs, as I alluded to, are not just in hospitals, but also in clinics and in the emergency departments where most of the antibiotics are prescribed.
You started out talking about inpatient and outpatient programs. For those folks who don't know, what's the difference?
Sure. If you're officially admitted into a healthcare facility, you are quote unquote an inpatient. Any care you receive during that stay would be considered an inpatient service. So if you're staying in a skilled nursing facility or a nursing home or staying in a hospital, that's all under an inpatient stay.
Okay.
You're outpatient if you're getting care at an emergency room or an urgent care clinic, or if you're just seeing your doctor in the clinic, or if you have surgery but only go in for the procedure. So anything under those kinds of stays would be considered outpatient.
Okay. And Tom, are most antibiotic stewardship efforts happening in the outpatient setting or no?
So I would say the greatest need is in the outpatient setting. If we all sit here and conceptualize, more patients visit outpatient clinics, more patients see their providers for non-acute illnesses and infections that aren't severe enough for them to go to the hospital. They go to their primary care provider and seek treatment, which a lot of time results in antibiotic prescribing. So in the outpatient setting, we see more consumption of antibiotics. However, right now, and traditionally, the focus has been antibiotic stewardship programs in the hospital because that's where we see patients come in with those really resistant bugs. And we first recognized that this was going on, that those patients were coming in really, really sick, and we didn't have enough to treat them. And as we traced it out, we figured out that as we were using more antibiotics in the community, that's what was really driving a lot of this problem. So the greatest need certainly is in our outpatient antibiotic stewardship arena. That's the big push nationally right now, is to tackle that. But as it stands, it's more common in the hospitals. But I think in the next 5 to 10 years, that'll be a 50-50 split, hopefully.
Okay, and let's talk about prescribing antibiotics for a minute. Why do they get prescribed when they're not needed?
Well, I think that's kind of an interesting question. Literature in medicine changes all the time. We get more information. There's new guidelines that are published. Within the last 10 years, we've found out a lot more about resistance, about what's driving resistance, about how better to treat infections. We know a lot of the acute upper respiratory infections, for example, when you have common colds, or most of the time are viruses, and we've had more literature published and guidelines that help clinicians now know more that that you can wait to get that antibiotic, or that certain symptoms coincide with more viral versus bacterial. So I think that traditionally we've seen prescribing driven because we just didn't have a lot of this information. As more and more comes out and we educate our patients and our providers and everybody more and more, I think we're in a better situation to actually tackle this.
And you talked about education, and that's a core element of antibiotic stewardship. What are some of the other things that healthcare providers are focusing on for antibiotic resistance?
I think one of the big ones is allergies. Patients a lot of times will state that they have a penicillin allergy, for example, and we know that very commonly it's stated somebody has a penicillin allergy, but we know nationally the true rates of penicillin allergies are less than 3%, and the severe ones are less than 1%. So that's something that we're focused on, because when we can't use that class of drugs, we have to use the bigger spectrum antibiotics, which again, we're trying to preserve those.
And many people are thinking, well, that's great. These people have antibiotic stewardship, but how do you actually operationalize it? And the CDC has given us core elements of stewardship programs for how actually to do this. And as you said, it includes a lot of education, but it also includes commitment, getting commitment from your senior leadership in either your clinic or hospital, trying to incorporate this into your daily policies and ordering protocols so that, again, it's reflex and not something you have to think about. And then tracking and reporting to make sure that you're actually watching your prescribing practices and tracking your resistance patterns. There's a lot that goes into it, but there are resources available.
Okay, great. And we are out of time. So now we know what healthcare professionals are doing to help battle antibiotic resistance and superbugs. What can you do about this? We'll talk about that right after this.